This is the quick dose of gout and hyperuricemia from Therapeutics Drive Clinical Learning for Pharmacists on the Go. This is part of the Therapeutics Drive podcast.
We are diving right in today.
Yeah, we are. So imagine a microscopic needle, like so sharp that it literally physically pierces your immune cells from the inside out.
That's a brutal visual.
Right, and it causes them to just explode and dump all these highly acidic inflammatory mediators directly into a joint space.
Just a complete biochemical disaster area.
Exactly. And that is the visceral, excruciating reality that your patient is experiencing when they literally hobble up to your pharmacy counter with a gout flare.
You can spot that walk from across the store.
Oh, 100%.
Yeah.
We're talking about one of the most common inflammatory arthritic conditions you'll see. It affects millions globally. But the management of this condition is just riddled with massive adherence issues.
It really is.
I mean, the biggest problem you face on the front lines is, a patient stopping their urate-lowering therapy right in the middle of a flare.
Which is the worst thing they could do.
The absolute worst.
Yeah.
Or they rely on that classic myth that they can just, diet away their gout by cutting out beer and steak.
Yeah, the I'll just drink cherry juice plan.
Right. So our mission today in this deep dive is to really arm you with the clinical mechanisms, the guideline-based toolkits, including the Australian Therapeutic Guidelines, or ETG, and the specific patient counseling scripts that you need to fix these adherence gaps.
Because to fix those gaps, you really have to understand the underlying pathology first.
For sure.
Fundamentally, gout is just a failure of uric acid metabolism and clearance. I mean, uric acid, it's a normal waste product, right? It's derived from the breakdown of purines.
Which come from both diet and our own DNA.
Exactly. Degraded endogenous DNA and dietary proteins. So in a healthy system, it stays water-soluble and it's excreted predominantly by the kidneys.
Okay.
But the clinical threshold you need to watch is a serum uric acid, or SUA, level above 6.8 milligrams per deciliter.
Which, for those using international units, translates to about 404 micromoles per liter.
Right. Above that, you've got hyperuricemia.
I always explain that specific number, that 6.8, to patients using an iced tea analogy.
Oh, I like that one.
Yeah, so imagine your bloodstream is a glass of iced tea. You can only stir so much sugar, which is the urate in this case, into that tea before the fluid reaches its absolute physical saturation point.
It just won't dissolve anymore.
Exactly. At 6.8 milligrams per deciliter, you've hit the physiological limit at normal body temperature. Any more sugar, and it just stops dissolving.
It crystallizes.
Yep, crystallizes and falls to the bottom of the glass. And in human anatomy, gravity and thermodynamics mean those urate crystals settle in the coolest, most distal extremities.
Which brings us to the big toe.
The classic big toe. Podagra. I mean, the big toe is literally the bottom of the iced tea glass. And because it's further from the heart, it's cooler than the body's core, so the solubility threshold drops even further.
That temperature dependence completely dictates the clinical presentation. But let's look at a critical nuance here that frequently trips up practitioners.
Okay, what's that?
Asymptomatic hyperuricemia is not gout.
That's a huge point.
It is. Roughly 80% of patients walking around with a serum urate above 6.8 will literally never experience a flare.
Wait, 80%? That's massive.
Right, because the precipitation of crystals, it requires this incredibly complex interplay of synovial fluid hydration, local pH levels, immune system priming. You don't just treat a number on a lab result if the patient is asymptomatic.
Okay, so pouring too much sugar into the tea is only part of the problem.
Yeah.
What about the drain? Like getting rid of it?
The drain is actually the primary culprit. When we think of high uric acid, we reflexively blame overindulgence.
Right, eating too much rich food.
We assume the patient is producing too much urate. But in reality, 90% of gout patients are under-excretors.
90%.
Yeah. Their renal transporters, specifically URAT1 and OAT4, in the proximal tubule, they are either, over-reabsorbing urate back into the blood or they're failing to secrete it into the urine.
Wow. Okay, so let's connect that to medication profiles.
Yeah.
Because you see low-dose aspirin on, almost every single cardiovascular patient's chart.
Oh, everywhere.
And I've had patients ask me, is my daily aspirin causing my gout? If aspirin inhibits uric acid excretion, why aren't all our post-MI patients just dropping like flies from gout attacks?
It's a great question, and it comes down to this really fascinating biphasic effect. Aspirin acts completely differently depending on the dose.
Okay, how so?
So at low doses, typically under 600 milligrams a day, which easily covers your standard 81 to 150 milligram cardio doses, Aspirin inhibits the tubular secretion of uric acid.
So it traps it in the blood.
Exactly, which does increase serum urate levels slightly. However, at high anti-inflammatory doses, like 3 or 4 grams a day, aspirin is actually uricosuric.
Oh, weird. So it flips.
It totally flips. At high doses, it blocks reabsorption and promotes excretion. But, and this is the crucial takeaway for you listening, if your patient is on low-dose aspirin for secondary cardiovascular prevention, the clinical consensus is firm.
Do not stop the aspirin.
Do not stop it. The documented cardiovascular survival benefit vastly outweighs a minor elevation in serum urate.
Okay, that makes perfect sense. So, time to move to the acute phase. The joint is literally on fire. Neutrophils have rushed in. They've attempted to, phagocytize those microscopic needle-like crystals, failed and ruptured.
Just spilled acid everywhere.
Yeah. And symptoms typically peak within 6 to 12 hours. We need to extinguish this immediately.
Right.
So the guidelines point us to 3 first-line monotherapy options.
Right.
You've got nonsteroidal anti-inflammatory drugs, or NSAIDs. You've got colchicine. And you've got systemic or intra-articular corticosteroids.
And selection among those 3 is entirely dictated by the patient's comorbidities.
You can't just pick your favorite.
Exactly. So you look at NSAIDs like indomethacin, commonly known as Indocin or naproxen. They are highly effective, but they carry severe risks for specific populations.
Right, like who?
You must avoid them in patients with active peptic ulcer disease, uncontrolled heart failure, and critically severe renal impairment.
Because of the kidneys.
Right. NSAIDs cause vasoconstriction of the afferent arteriole in the kidney. So if a patient is already an underexcretor of urate due to chronic kidney disease, dropping their glomerular filtration rate even further with high-dose indomethacin?
That's a massive clinical error.
A huge error.
Okay, so if the kidneys are compromised and NSAIDs are off the table, you might think of targeting the neutrophils directly instead of just the broader prostaglandin pathway.
No.
Which brings us to colchicine, available under the brand name Colchris.
Yes, and colchicine has this brilliant, highly specific mechanism of action.
How does it work exactly?
So it binds to tubulin. Tubulin is the structural protein that forms microtubules inside cells.
Okay, like the skeleton of the cell.
Exactly. By preventing microtubule polymerization, colchicine essentially destroys the cellular scaffolding of the neutrophils. The neutrophils physically lose the ability to migrate to the joint space.
Oh, wow.
Yeah, they can't move, so they can't cause inflammation.
That is wild.
It is, but this efficacy is highly time-dependent. It must be initiated within the first 36 hours of symptom onset.
Because after that,
the neutrophils have already infiltrated the joint. The drug's effectiveness just plummets.
Okay, so what if the patient misses that 36-hour window and they still have terrible kidneys? We can't use NSAIDs. Colchicine is too light.
Then corticosteroids step in. Oral prednisone or prednisolone. They are safe for the kidneys and highly potent.
But there's a trade-off.
Always a trade-off. It's the metabolic impact. A systemic steroid burst in a patient with poorly controlled diabetes will cause extreme blood glucose spikes. You have to monitor their glycemic control closely.
Right. And while the patient is waiting for the pharmacy to fill any of those prescriptions, there's a really simple physical intervention you should recommend.
Ice.
Yes. Tell them to put an ice pack on the joint. It's so basic, but topical ice application causes local vasoconstriction, which physically slows down the leukocyte trafficking into the joint space.
It significantly decreases pain and swelling in acute flares.
It's basically pharmacology by thermodynamics.
That's a great way to put it. Now, once the flare resolves, the acute treatment stops. The patient is comfortable, but the underlying hyperuricemia remains.
The iced tea is still saturated.
Exactly. So to prevent irreversible joint destruction, we transition to urate-lowering therapy, or ULT.
Okay, so who actually gets ULT?
The American College of Rheumatology and the ETG guidelines are really specific here. You initiate ULT for patients who experience 2 or more flares annually, patients with visible, chalky subcutaneous tophi, or those with radiographic evidence of joint damage.
Got it. And the ultimate goal is a treat-to-target strategy. You want to drive the serum uric acid below 6 milligrams per deciliter, or under 357 micromoles per liter.
Right.
But, and this is massive, this phase is where therapy fails. Like, I am going to put on my consultant pharmacist hat for a moment here, because knowing how to counsel a patient during ULT initiation will literally make or break their adherence.
It's the most critical conversation you'll have with them.
It really is. So when you dispense a drug like allopurinol, it rapidly drops blood urate levels. This creates a steep concentration gradient. The crystallized stores of urate that are embedded deep in the joint tissues, they begin to dissolve and mobilize back into the bloodstream to be cleared out.
And this creates the dreaded mobilization flare.
Exactly. Think of it like cleaning out severely neglected gutters on a house.
Oh, that's a good analogy.
Right. To get the system flowing again, you have to scrape the bottom, stir up all the decaying leaves and muck, and flush it down the spout. When allopurinol stirs up those crystallized tissue stores, the immune system detects the shifting crystals and mounts a massive attack.
It triggers an agonizing gout flare.
And the patient very logically thinks, okay, I started this new daily pill on Monday, and by Thursday, I had the worst gout attack of my life. This pill is poison.
And they throw it away?
Yep, straight in the trash. So as the pharmacist, you must preempt this psychological trap.
And the clinical intervention here is mandatory prophylaxis.
Tell us about that.
The guidelines require that when you initiate a urate-lowering therapy, you must simultaneously prescribe an anti-inflammatory prophylaxis.
Like what?
Typically low-dose colchicine, such as 0.6 milligrams once or twice daily, or a low-dose NSAID. And this protective umbrella must continue for 3 to 6 months after the target SUA is achieved.
Right, so you hand the patient the allopurinol and you say, this medication is going to scrub the uric acid out of your joints. But while it's cleaning, it stirs up the debris, which can cause a flare. That flare actually means the drug is working.
That's brilliant framing.
And so I am giving you this second medication, colchicine, to act as a shield while the allopurinol does the heavy lifting.
That script saves the therapy. It really does.
Since we dispense these specific agents constantly, let's dive into their pharmacological profiles, starting with colchicine's safety margins.
Good idea. So for acute flares, the FDA-approved dosing is narrow and strict. It's 1.2 milligrams at the first sign of a flare, followed by 0.6 milligrams exactly 1 hour later.
And then you stop?
And you stop. The major safety issue here is fatal toxicity. Colchicine has an incredibly narrow therapeutic index. It's a major substrate for both the CYP3A4 enzyme and the P-glycoprotein efflux pump.
Which means interactions are a nightmare.
A total nightmare. Co-administering colchicine with a strong CYP3A4 inhibitor like clarithromycin shuts down its clearance pathways. The drug accumulates rapidly, leading to severe systemic toxicity.
I always warn patients about the gastrointestinal side effects, the nausea, vomiting, and diarrhea, because patients often assume GI upset is just a standard, annoying side effect they have to power through, like with antibiotics.
Right, they think, oh, my stomach is just a bit upset.
Yeah, but you have to reframe that for them. Those GI symptoms are not a nuisance. They're the rumble strips on the highway.
A very accurate comparison. GI distress is the initial clinical manifestation of impending cellular toxicity.
Wow.
If a patient ignores the rumble strips and keeps taking the drug, they drive straight off the cliff.
Into what?
Into neuromuscular toxicity, multi-organ failure, and profound bone marrow suppression.
So if a patient on colchicine reports severe, uncontrolled diarrhea,
you halt the therapy and evaluate immediately, no questions asked.
Good to know.
Yeah.
Okay, let's transition to the anchor of long-term prevention. Allopurinol, which is widely recognized by the brand name Xylprim. It's a xanthine oxidase inhibitor.
Right. Allopurinol halts the production of uric acid by blocking xanthine oxidase. That's the enzyme responsible for converting hypoxanthine to xanthine and xanthine into uric acid.
It's the gold standard.
It is the undisputed first-line agent. But it carries the risk of allopurinol hypersensitivity syndrome, or AHS.
I actually had a patient read the warning label for Xylprim, see the word rash, and panic. They thought they were going to get, mild contact dermatitis.
Oh, it's so much worse than that.
I had to explain that we aren't talking about a mild itch. AHS can progress to toxic epidermal necrolysis or Stevens-Johnson syndrome. We were talking about the epidermis literally separating from the dermis and blistering off.
And the mortality rate for that is staggeringly high.
It's terrifying. So what causes it?
The pathophysiology behind AHS is deeply tied to genetics. The risk is strongly associated with the HLA-B5801 allele.
HLA-B5801. Got it.
Yes. This specific genetic marker alters the physical shape of the major histocompatibility complex. When a patient with this allele takes allopurinol, their antigen-presenting cells display the drug in a way that makes the T cells identify it as a deadly invasive pathogen.
So the immune system goes rogue.
Exactly. It launches a catastrophic attack on the patient's own skin cells.
Okay, so who needs to be genotyped for this before we dispense that first bottle?
Clinical guidelines mandate screening for populations with a high prevalence of the allele. This includes patients of Southeast Asian descent, specifically Han Chinese, Korean, and Thai populations, as well as African American patients.
And if they test positive?
If the test returns positive for HLA-B 5801, allopurinol is absolutely contraindicated. You cannot give it to them.
Okay. But for patients who clear the screening, dosing strategy is paramount. Start low and go slow. The initial dose should never exceed 100 milligrams daily. And if the patient has stage 4 or worse chronic kidney disease, you start at 50 milligrams.
The renal adjustment is critical because of allopurinol's active metabolite, oxypurinol.
Right, because allopurinol itself has a really short half-life, right?
Exactly. It's the oxypurinol that does the heavy, sustained enzyme inhibition. And oxypurinol is cleared almost entirely by the kidneys.
So if the kidneys aren't working,
In a CKD patient, oxypurinol just accumulates, and high plasma levels of oxypurinol are a primary driver for developing AHS. You can still escalate to target doses in renal impairment, but you must titrate incredibly slowly and monitor serum levels meticulously.
okay, but what if a patient has a severe hypersensitivity reaction? Or they simply cannot reach the target uric acid level despite maximum titration?
Then we turn to the alternative xanthine oxidase inhibitor.
Right, febuxostat, known by the brand name Uloric.
Yes. And pharmacokinetically, febuxostat is highly appealing. It relies heavily on hepatic metabolism rather than exclusive renal clearance.
Oh, so you don't need to adjust the dose for mild to moderate renal impairment.
Exactly. For our CKD patients, that is a massive logistical advantage.
But it comes with a formidable black box warning regarding cardiovascular safety.
It does. The CARES trial, that's the cardiovascular safety of febuxostat and allopurinol in patients with gout and cardiovascular morbidities, it really changed the landscape for this drug.
What did it find?
The trial demonstrated a statistically significant increased risk of cardiovascular death and all-cause mortality in patients taking febuxostat compared to those on allopurinol.
That's concerning.
Very. The exact mechanistic reason for this increased cardiovascular toxicity remains debated, but the clinical directive is totally clear. Febuxostat is strictly a second-line agent.
And this is exactly why you see step therapy protocols in practice. For instance, in Australia, to access febuxostat through the Pharmaceutical Benefits Scheme, or PDS, the prescriber must document that the patient has a true medical contraindication to allopurinol or has experienced a documented treatment failure.
You cannot simply jump to the more convenient drug.
You really can't. Okay, let's shift gears to practical management and tackle the lifestyle interventions, because you will inevitably counsel a patient who insists, I'm going to fix this with my diet, I'll stop eating red meat, I won't drink beer, and I won't need these daily pills.
It happens all the time.
The motivation is great, obviously, but the biochemistry just doesn't support it. Strict low-purine diets are notoriously miserable for patients to maintain.
You're so restrictive.
And furthermore, even perfect adherence to a restrictive low-purine diet typically only drops the serum uric acid by about 1 milligram per deciliter.
Just one.
Just one. So if your patient is sitting at a 9.5, cutting out steak is not going to get them below the 6.0 target.
It's just math at that point. So instead of focusing on extreme restrictions, evidence actually supports the DSH dietary approaches to stop hypertension.
Okay, so more balanced.
Yeah, emphasizing vegetables, low-fat dairy, and whole grains. It not only modestly lowers urate, but it addresses the metabolic syndrome and cardiovascular comorbidities that really plague the gout population.
So you validate their effort to eat better.
Exactly, validated. But you firmly explain that pharmacological intervention is almost universally required to actually cross the therapeutic finish line.
And crossing that finish line requires active monitoring. You don't just hand over a 100 milligram prescription of allopurinol and tell them to come back next year.
No, absolutely not.
During the titration phase, you need to check the serum uric acid every 2 to 5 weeks. You evaluate the lab, you increase the dose, you check again.
It's a very active process.
Right. Once you've driven the number below 6 and the patient is clinically stable with no flares, then you can relax the monitoring to every 6 months.
It really demands a highly proactive approach from the pharmacist to ensure the patient doesn't get lost to follow up during that critical titration window.
For sure. All right, let's distill all of this pharmacology down into actionable knowledge. We are going to arm you with 4 rapid-fire pharmacy pearls that you can literally deploy on your next shift.
Let's do it.
I'll start with pearl number 1. Never stop allopurinol during an acute gout flare. If a patient is already stabilized on allopurinol and they suffer a breakthrough flare, you must keep them on their maintenance dose.
Do not touch it.
Right. Stopping the drug causes a rapid, massive fluctuation in serum uric acid levels, which will only pour gasoline on the fire. You treat the acute inflammation with NSAIDs or colchicine, but you leave the urate-lowering therapy alone.
Okay, parole number 2. Always mandate prophylaxis. When you initiate a urate-lowering therapy, you must concurrently dispense an anti-inflammatory like low-dose colchicine or an NSAI.
The shield.
Yes, the shield. You have to provide a protective shield for 3 to 6 months to prevent the mobilization flares from destroying the patient's adherence.
Love that. Pearl number 3. Time is joint tissue. When a flare hits, rapid treatment is the only metric that matters. Initiating an NSAID or colchicine within the first 24 hours of symptom onset yields drastically better outcomes.
Once you cross the 36-hour mark.
Yeah, once you cross 36 hours, the neutrophils have established a stronghold in the joint, and the efficacy of agents like colchicine drops off a cliff.
And finally, pearl number 4. Respect the rumble strips. Monitor vigilantly for colchicine drug interactions, specifically with strong CYP3A4 or P-glycoprotein inhibitors.
Check those medication profiles.
Counsel every patient that gastrointestinal upset, the nausea and the diarrhea, is not a trivial side effect. It is the immediate precursor to severe, potentially fatal systemic toxicity.
You now have the deep clinical mechanisms, the specific guideline pathways, and the patient counseling analogies to completely transform how you handle gout at the pharmacy counter.
You know exactly how colchicine paralyzes neutrophils, why aspirin has a biphasic effect, and how to navigate a patient through the treacherous mobilization flare of allopurinol.
If you want a deeper breakdown of gout and hyperuricemia, including treatment pathways and clinical nuances, check out the full dose version of this episode.